And so the information that we're going to go over today is more terminology. We're also going to talk about movements like flexion and extension, and kind of give you guys a description of it, so you guys have a better idea of the movements. And again, this will be something that we will go over again the first week of class, and these will be items that you will be tested on in the quizzes, in the daily quizzes. So this information will most likely be within the information for the first two quizzes of, that you're going to have on that Monday and Tuesday on the 11th and 12th. So let me pull up the screen. Righty. Can you guys see this?
Yes.
All right, let me just go to a slideshow. Hopefully it will show better. Hey, come on. Okay. Yeah, I had it. I'm sorry, give me 1 second. Technology. There we go. All right, can you see that one? It's on the whole screen, so I think that's a better view. All right, so what we're going to do, like I said, this is basically a lot of terminology, some basic information that I want you to know that you won't be tested on, and I will tell you what you will and won't be tested on. So this way you have a good idea. All right, so the first thing we're going to talk about is anatomic position. Now, the anatomical position, it's the starting point for all movements. Here's the thing, when we do movements in all different ways. On the next screen, we're going to talk about different planes and how movement occurs in each of these planes. The problem is we have to have a starting point. And the starting point in the medical world is the anatomical position. So every movement that we perform and every movement that we go over today, you always want to think of it within the starting position of the anatomical position. So the important features, all right, and this is something you will be tested on, and they have actually asked this question on the national exam. So some of the features of the anatomic position is that you're going to be standing erect, standing straight up. Your head, your eyes, and your toes are directed anteriorly, directed to the front. Let me just make sure that I am taping this. My apologies. For some reason, I can't see whether I'm taping this or not. Oh, okay, I am. Fantastic. Now I can get back to this. All right. And we'll put that. So again, the anatomical position is you're standing straight up. Your head, your eyes, and your toes are directed frontwards or anteriorly. Your arms are at your sides with your palms facing anteriorly. And your lower limbs, your legs, are close together with your feet parallel and your toes, again, directed anteriorly or in the front direction. So every movement that we do, you've got to consider it from this position. And we do that for many reasons, but the most important reason is that we move in planes. We move in different planes. What that means is that every movement that we do is kind of different. So what we do is we direct it according to what we call planes. Now, a plane is basically an imaginary flat surface that passes through the body. Think of it like a piece of glass going through your body. All right, we have three important planes that you need to know. The first plane is the medial plane. Now, the medial plane divides the body into a right and left half. All right, the medial plane is also known as the sagittal plane. So it's this piece of glass here. This piece of glass here. And it splits the body into a left side, let's say, and a right side. And we have certain movements that correlate with these planes. All right. So when we talk about flexion, all right. So if you were to put your hand to the side and then bring your arm up fully above your head, it goes along the sagittal plane. All right. It goes along the sagittal plane in flexion and in extension. So again, the sagittal plane divides the body into right and left halves. The next plane is the frontal plane. And I'm giving you both words because they can be used in any way. They can say frontal plane, they can say coronal plane. You have to know both of them. The frontal or the coronal plane is where the plane divides the body into anterior and posterior halves, or front and back. So that glass goes into the head and down into the body and splits the body into an anterior and posterior portion. Some of the movements that occur in this plane is, and we're going to talk about all these movements later, so you're going to hear it again, is abduction, where you bring your arm away from your body, and adduction, where you're bringing your arm back towards your body. So again, the frontal plane divides the body into front and back, or anterior and posterior halves. The final plane that I need you to know is the transverse or horizontal plane. This plane basically kind of goes through, let's say, the stomach, and it divides the body into an upper and lower half, or superior and inferior portions. Most of the rotations that we do goes along the transverse or horizontal plane. So when we get to the movements a little bit later, we will talk about what plane these movements occur in. When we're talking about the movements occur along the plane. They don't go through it. So for example, that median or that sagittal plane that divides the body into right and left halves. Well, if I abduct my arm, I'll be going through that plane. I won't be moving along it. But when I flex and extend my shoulder, I'm moving along the plane. I'm not going through that piece of glass, that imaginary piece of glass. So the three planes that you need to know are the median plane, also known as the sagittal. Again, splits the body into right and left halves. The coronal or the frontal plane, which splits the body into an anterior, posterior, or front and back portions. And the transverse or horizontal plane, which divides the body into an upper half and a lower half, or superior, inferior halves. it doesn't. Okay. So again, here's the planes split up into each. So if we look at the left-hand picture, this is the median or sagittal plane. Again, this plane divides the body into right and left halves. In the middle, we have the frontal plane. The frontal plane divides the body into anterior and posterior, or front and back portions. And the transverse or horizontal plane divides the body into upper and lower halves, also known as superior and inferior halves. So some of the basic terminology that you're going to need to understand this. This is basically a new and different language, all right, that you're going to have to understand. A lot of those basic terms that I just gave you, like upper and lower, front and back, left and right, we really don't want to use a lot of those terms. We have to use them more in a medical sense. So these next terms you're going to basically make friends with for the rest of your careers. All right. These terms basically describe the position of the body. And it describes the position of the body when we move. And it talks about where the muscles and bones are located. With some of these, you're going to hear multiple terms used. Again, like I said earlier, what happens is that the national exam can use any of these terms at any time that they want. So you've got to understand them all and correlate them maybe with something that's just a little bit easier sometimes. All right, so when you're starting to study these terms, try to correlate them to something easier, such as you got the anterior and posterior is, I said it was front and back. Okay. You got upper and lower, we have superior, inferior. Okay. So these are some of the things that I want you to think about. So with these terms that I have here, I kind of put them together because they are kind of opposite to each other. And that's also a good way to learn it. So again, the first set of terms is superior and inferior. Superior means towards the top of the body. Again, you might hear this term as cranial. Inferior means towards the bottom of the body. You might hear caudal. All right, so superior and inferior, towards the top of the body, towards the bottom of the body. Anterior and posterior. We spoke about the front and the back. Well, the anterior means towards the front of the body. Another word that you will always hear for the front is ventral. Anterior equals front equals ventral. Any of those terms can be used. Posterior means towards the back of the body. The word for that is dorsal. So ventral means front, dorsal means back. Anterior means front, posterior means back. Okay, you've got to know all those terms. Next, we have medial and lateral. Medial means towards the midline or the center of the body. Lateral means away from the midline of the body, going towards the side. So medial and lateral. We have proximal and distal. A structure that is proximal is closest to the point of attachment. A structure that is distal is furthest away from the attachment. So let's talk about the elbow. Let's talk about the elbow and the tips of the fingers. In relation to the shoulder, the elbow is more proximal and the fingertips are more distal. The elbow is closer to the attachment point, so it's proximal. The fingertips are further away from the attachment, so that is distal. You will hear proximal and distal an awful lot. And if you look at the picture here, let me pull up my pen eventually. There it is. So it's talked about right here where proximal and distal are. All right, the proximal end is this end here, closer to the attachment. The distal end is here. Take a look at the arrows. Proximal is pointing upwards. Distal is pointing down towards the hand. So again, proximal, closer to the point of attachment, and distal, further away from the point of attachment. The next two is superficial and deep. And we use this an awful lot as physical therapist assistants when we're talking about muscles. We have muscles that are closer to the skin or closer to the surface of the body. Those are superficial muscles. And then we have other muscles that are further away from the surface of the body. Those are considered deep muscles. For instance, let's take pectoralis major and pectoralis minor. Pectoralis major is that big muscle on your chest. All right, it attaches to your sternum, it attaches to the clavicle, and it actually inserts on the forearm. Actually inserts in the bicipital groove. Well, that's a very superficial muscle. It's very close to the skin. The pectoralis minor is underneath the pec major. And it doesn't always work that way, by the way. All right, it doesn't always work that way. But in this case, it does. The pec minor is under the pec major. See, the pec minor inserts onto the rib, the origin is on the ribs, and it inserts onto the coracoid process. So when the muscle or the structure is closer to the skin, it's superficial. When the structure or the muscle is further away from the surface, it is considered deep. Now, here's some other terminology that you're going to need to know. And this is basic terminology. When we're talking about, this is more for movement and for direction. When we get to each of the next few classes, you're going to learn a lot of different terminology. So this is the basics. This is what's going to get us going. So when we're talking about both sides of the body, the word we use is bilateral. When we talk about one side of the body, we say unilateral. For instance, the sternocleidomastoid is a muscle in our neck. Its origin is actually on the sternum and the clavicle, and it inserts sternocleidomastoid on the mastoid process. When they work together, when they work bilaterally, they flex the neck. It does this motion, it flexes the neck. when it works on one side, so let's say the left sternocleidomastoid is activated. Well, when one muscle works, when the left side works, it actually laterally it laterally flexes the head and rotates the head in the opposite direction. So you're going to have to understand what muscles do what, and if there's muscles on both sides that work together, they're probably going to do some different things. So bilateral means both sides, unilateral means one side. Contralateral means the opposite side of the body. So again, when I'm talking about the left sternocleidomastoid, what happens is it rotates contralaterally and it laterally flexes ipsilaterally. Ipsilateral means on the same side of the body. So the sternocleidomastoid has a couple of different actions. When they work bilaterally, when both of them work at the same time, it flexes the neck. When only one side is working unilaterally, well, it laterally flexes to the same side or ipsilaterally, but it rotates contralaterally to the opposite side. So contralateral means opposite, ipsilateral means same side. Anybody got a question? Good. Those are kind of tough, but again, ipsilateral, same side, contralateral, opposite side. Some of the important terms you're going to need to know is what position somebody is in. Well, the supine position is lying flat on your back with your face upwards, where the prone position is lying face downwards. The side lying position, that's pretty easy, thankfully, lying on your side. The hook lying position is lying in the supine position with your face upwards, but with your knees bent. That is known as hook lying. The quadruped position is when you are on your hands and knees. All right, quadruped, 4. You're on your hands and knees. You will hear the Trendelenburg position. The Trendelenburg position is where the patient is lying supine, but the table is tilted. It's tilted in such a way that the pelvis is higher than the head, which means when the table is tilted, the head is in the down position. The head is down here and the pelvis is up here. So again, Trendelenburg position, patient is lying in the supine position on a tilted table or bed with their head lower than their pelvis, or their pelvis is higher than the head. So it would look something like this. Oh, let me go back. So if this was the table, the head would be here. Please, I apologize for my drawings. I am definitely not an artist. And let's say the pelvis was this area here. This is where the pelvis is higher than the head, the Trendelenburg position. And finally, cephalic is the same thing as superior and cranial. It means near the head. So again, you guys are going to be learning a lot of new terminology. It's just going to take time, but you got to use it. If you don't use it, then when we say it to you, you're going to have a difficult time understanding it. We're going to test you using this terminology, and the national exam will test you using all kinds of different terminology. Any questions on the terminology? Doing okay so far?
Yep.
Excellent. All right. Just don't want to move sometimes. Okay. So like I said yesterday, we're going to be talking about regions of the body also. And there's certain terms that you're going to need to know. I'm not going to test you on this, but you're going to need to know some things about the body regions and how it's split up, because you're going to hear about these regions, and I'm going to want you to know about it. So remember yesterday when we talked about the axial skeleton, that was the base structure of the body. Well, the axial region is the head, the neck, and the trunk. When we're talking about the thoracic region, we're talking about the area above the diaphragm. And when we talk about the abdominal region, we're talking about the area below the diaphragm. So the diaphragm is like a center area. Now, the abdominal area is split up into quadrants, different quadrants. Now, I will not test you on these quadrants, but I want you to understand them. All right. You don't have to memorize where all the body parts are and where all the structures are, but just understand that you might hear that, the patient is having pain in their right upper quadrant of the abdominal area. So we want you to understand what those terms mean. So the abdominal is split up in different ways. All right. So if we take a look on the right-hand side, it's split into four parts. And this is the basic setup of the quadrants. We have a right upper quadrant and a left upper quadrant. We have a right lower and a left lower. And what you'll see is folks that have abdominal issues, they'll actually use the quadrants on the left because it's actually more specific. All right, the right hypochondriac area, the right iliac region. Guys, don't freak out. I am not testing you on this. There will be no exam questions on abdominal quadrants. I just want you to know that if you hear this, that you have an understanding of it. Just get a good understanding definitely of the one on the right. It makes much more sense. Right and left upper, right and left lower. All right. What they also have done is they have split up the organs into those 9 regions on the left. So we got the tic-tac-toe box here on the left-hand side. Well, you can actually, say, which organs are within which quadrant. And that's what this next one is. And again, I don't want to make anybody nervous. This will not be on any quiz. It won't be on anything. You will not be tested on this. But as you can take a look, you can see that the body structures are split into these quadrants, and it makes it easier for doctors and nurses to talk about location. Okay? That's what these quadrants are for. So one more time, you guys will not be tested on the quadrants of the abdominal cavity, nor will you be tested on the organs within these quadrants. I just want you to know that if you hear it, you have an understanding that, oh, okay, I remember Mr. Dunn talking about right and left quadrants of the abdominal area. Okay, beautiful thing, fantastic. Let's go on. So again, you will not be tested on this. But this you will be tested on. Remember yesterday we spoke about how there are medical terms for basically each of the body parts. Well, you need to understand these terms. These are the terms of the appendicular bones, basically the arm and the leg. So let's start at the top. Basically, the humerus is the arm region, or known as the brachial region. The brachial region is basically the humerus area. There's a bunch of nerves in that area that's known as the brachial plexus. So if you kind of forget where the brachial region is, think of where the brachial plexus is. It basically is in the armpit area where the nerves come out and into the arm. So the brachial region is the humerus, the upper arm. The forearm is known as the antebrachial region. Right? So you got the brachial and antebrachial regions. The wrist is known as the carpals. Remember yesterday we went over the 8 carpal bones. The palmar region is the palm of the hand. Thankfully, that's pretty easy. And the fingers are known as the digits. In the lower limb, the thigh or the femur itself is the femoral region. The lower leg, made up of the tibia and the fibula, is known as the crural region. And you'll hear that especially when we're talking about the back of the knee. That's really an important part known as the crural region. The ankle is known as the tarsal region. Remember, the tarsal bone articulates with the medial and lateral malleolus. The foot is the pedal region. Best way to know that is stepping on the gas, putting the pedal to the metal. I'm putting my foot down on it. Foot is the pedal region. And just like the fingers, the toes are also known as the digits. So you need to know the medical term for each of the regions of the arms and the legs. And here's a picture of all of these regions. We got the cranium. We have some other things. We have like the mouth is known as the oris. I'm not going to ask you that. But you should know that the armpit is actually known as the axilla. All right, that's an important region. When we're talking about the cheek, they call it bucca, because one of the things is when we take medication, we might just take it where we put it in the cheek. It's called buccal, taking it buccally. The gluteus region, that, definitely know that because the 3 glute muscles, glute max, glute medius, and glute minimus, are all glute muscles, all the muscles of the buttocks. So this is a good picture, not something you need to study like go crazy about, but get an understanding because these are all medical terms that are going to be used a lot. This is another part that I am not going to put on any of the exams, but I want you to understand that the body has many cavities, and within these cavities are the organs that basically keep us alive. So We have the cranial cavity. And again, I'm not going to test you on this, but you need to know where these structures are. The cranial cavity, that's where the brain is and the pituitary gland. All right, we have the spinal cavity, the vertebral foramen going through all those vertebrae. That's where the spinal cord is located. We have the thoracic cavity, where our heart and lungs are. We have the abdominopelvic cavity, that big space where we have basically all of our major structures: stomach, intestine, liver, kidneys, right? All of these things. So I want you to have an understanding of these cavities. Again, I will not be testing you on it. The cranial cavity, again, has the brain. It's lined with meninges, all right, and fluid. The vertebral column contains the spinal cord, again, lined with these meninges. That's part of it, and that hopefully you'll have an understanding of that from your A&P classes. And again, you got the thoracic cavity, abdominopelvic, abdominal and pelvic cavities. And again, I will not be testing you on this. All right, I just want you to know that they are there. All right, to kind of go through them just a little bit so that you know, the thoracic cavity is kind of split up into three parts: the mediastinum, the pericardium, and the pleura. All right, the mediastinum is the area around the lungs. The pericardium is around the heart. So, some of the words that you're here, and pleura is around the lungs. Abdominal cavity is basically split up, all right? And that's where most of the major structures of the body are located: the digestive organs, the kidneys, the bladder. So, again, just know where they are. All right, getting towards more physical therapy stuff. So what we're going to go over is the basic movement of the body. These are terms that you're going to use for the rest of your careers. We use them every single day. All right? And you're going to be expected to understand and use them accordingly. And what I mean by that is you're no longer going to be you're no longer going to be bending your elbow. That is now known as flexion. When a patient rolls their ankle, or if you see in sports, somebody rolling their ankle over, your head's going to go, and they severely inverted their ankle. And when you're ready to point your foot like a ballerina, sorry, Giancarlo, I can do it too. When you point your toes downwards, you're no longer pointing your toes, you're actually plantar flexing your foot. So we're going to go over each of these movements, and I'm going to try to go over each of the body parts that perform the movements in each way. And I'm going to kind of give you the planes that it occurs in. So remember those planes: sagittal plane, the coronal and frontal plane, and the transverse or horizontal plane. So we'll talk about each one of them. So when we're talking about movement in physical therapy and as physical therapist assistants, we're talking about range of motion. If you see the letters ROM, it means range of motion. And range of motion is defined as the distance and direction a joint can move to achieve its maximum potential. Now, every joint has a maximum potential. It has a maximum degrees of motion it can perform. So each motion has its own and different range of motion. And range of motion is expressed in degrees. For example, your knee can flex to 130 degrees. So if you were to hold your arm out to your side, all right, that's the neutral zero position. And if you were to raise your arm in front of you and over your head, you would have performed a range of motion probably close to 180 degrees. All right. And we take a measurement tool known as a goniometer to measure that. That's something you'll learn in your 4th month in our patient care class. Actually, the class that's going on right now. So every joint has a certain range of motion. Elbow flexion, you have about 130 degrees, 140 degrees of that motion. Elbow extension, you have 0. You might even have some what we call hyperextension. So again, range of motion is the distance and direction a joint can move. Now, range of motion can be performed in 3 different ways. And you guys are going to need to know this. The first way is passive range of motion. You will see that as PROM. Passive range of motion means that a therapist or equipment is moving the joint through the range of motion with no effort from the patient. Think about this. If we have a patient that cannot move, we still need to move their joints to maintain them, or they're going to get tight and painful. So we perform passive range of motion on these patients to all of their joints. And that's where we move each of their joints through their available range of motion. If I was, let's say I wanted to do shoulder flexion. Again, shoulder flexion is bringing your arm in front of you and over your head. But I couldn't do it with my right arm, but I can move my left arm. I might use my left arm to lift my right arm. That is passive range of motion. Again, I can't move the right arm. There's no effort with the right arm. So I'm using my left arm, or in that case, it would be equipment, my left arm, to move my right arm. So again, passive range of motion means that the patient is not moving by themselves. They need a therapist, another body part, or equipment to move the joint through its available range. Active assisted range of motion, AARM, means that the patient will use their muscles up to what they can perform. So the normal shoulder flexion is 180 degrees. Let's say on my right arm, I move it up, I can only get to 90 degrees. So I'm moving it by myself, but I can't go through my full range of motion. So I use some outside help to bring it up through its available range of motion. So I'm actively moving my arm through what I can do, but I'm completing it with assistance. So active assisted range of motion means the patient uses their own muscles to perform the exercise, but they require some help from the therapist or equipment to go through their full range of motion. So again, passive range of motion means the patient cannot move the joint. They need help. Active assisted means I can move it a little bit, but I can't move it through the full range of motion. Active range of motion, or AROM, means that I can move my joint through the whole range of motion without any assistance at all. Okay? So active range of motion means that I'm doing all the work. So if we were to put it in that sense, the passive range of motion, I can do no work. I can't move. Now you got to understand something. You guys are pretty healthy. You're going to have patients that really can't move their body parts. And you're going to have to perform passive range of motion. Some patients can only move a little bit. You're going to have to help them through or assist them to complete the range of motion. That's active assisted range of motion. And finally, you're going to have patients that can perform the range of motion all by themselves without any assistance. And that's known as active range of motion. Any question on ranges of motion? We're good with that? All right. So let's go through these movements. The first movement is known as flexion. Flexion, as a definition, basically means that it's a movement that decreases a joint angle. So I'm going to kind of go through each of the joints. In order to perform neck flexion, you're bringing your chin towards your chest, chin to the chest. Shoulder flexion, your arm is at your side, you bring it straight up above your head. That's shoulder flexion. Elbow flexion is bringing your hand towards your shoulder, just like this picture, flexing the shoulder. Wrist flexion is where we bring the wrist downwards. Finger flexion, bringing the fingers downwards. Hip and trunk flexion, bending over or bringing the hip upwards, or just being in the seated position. Knee flexion is bending your knee. There are special terms for the ankle, and we'll go over that later. The next movement, also let me just say, flexion occurs in the sagittal plane. All right, flexion occurs in the sagittal plane. Remember, the sagittal plane splits the body into right and left halves. So if I got a piece of glass separating my body into right and left halves, and I do elbow flexion, notice how it goes along the piece of glass. It doesn't make contact with it. So flexion and extension occurs in the sagittal plane, except for the thumb. And we'll talk about that. Extension is the opposite of flexion. It's where the angle increases. It's where we're straightening out a limb, all right? Or we're returning the body part to the zero position. So extension of the neck is bringing your head backwards. Extension of the shoulder is returning it back to zero and also going backwards. So going forwards with your shoulder is flexion. Going backwards with your shoulder is extension. Extension of the elbow is returning it from the flexed position, just like the picture. Extension of the wrist is bringing your wrist backwards. Flexion is forwards. Extension is backwards. Extension of the fingers is bringing the fingers back. Flexion of the hip is bringing a straight leg behind you. Extension of the knee is bringing it back to the zero position from flexion. And ankle extension has a special name, and we will talk about that in a bit. We do have a special movement known as hyperextension. Some people, and you might have heard this as double jointed. So some folks have more extension, and you'll see this usually in the elbow. So if you take a look at the top picture, the lady there, right, the normal range of motion is 0 or 180 degrees. Well, if you notice, her hand is really underneath her arm there. It kind of goes straight and then down. That is a hyperextended elbow. And she actually has more motion than she should have, than normal. But it might be normal for her. She might have a hyperextended elbow on both sides. So hers is normal. You'll also see hyperextension in the knee. So if you take a look at the bottom picture on the left-hand side, we have a red dotted line that's kind of going through it. The one on the right is a perfectly extended knee that's totally straight. A hyperextended knee is a very dangerous position for people. They can get really, really hurt. They can tear a lot of musculature with a hyperextended knee. So this is something that we will need to work on our patients as physical therapist assistants. So hyperextension means more extension than normal, extension past the regular position. So again, flexion and extension occur in the sagittal plane. AB and adduction. Abduction occurs when the bone moves away from the midline. So if you take a look at the picture on the left, the young lady is starting in the anatomic position, and she's moving her hands, her arms outwards to the top. That's abduction of her shoulders. Abduction, moving away from the body. Adduction is moving back towards the body. So again, looking at that same picture on the left side, she starts from the top and she's coming downwards. That's adduction, where the movement is going towards the body. We usually have AB and adduction at the shoulder, at the hip, and we also have it at the ankle too. And AB and adduction occur in the frontal plane. Remember, the frontal plane divides the body into front and back halves. If you take a look at the movement, well, the movement is actually splitting the body into front and back halves. So abduction and adduction. Abduction, moving away from the body. Adduction, moving towards the body. Good way to remember it, when you're doing adduction, you're coming back to the body. All right? There's another special movement that's known as circumduction, and this is a circular movement. You'll see this movement at the shoulder and at the hip. This is a non-planar movement, which means that it's actually going through all the planes. Circumduction is a movement that combines flexion, abduction, extension, adduction. And you will see this mostly with patients that are having trouble ambulating. They're unable to bring their leg forward. They don't have the strength. So they'll actually bring it out sideways and around in a circular fashion. So you'll see circumduction usually when people are walking. So again, this is a circular movement. Another important motion is internal and external rotation. You see this at the shoulder and at the hip. So if we look at the lady on the left picture, she's bringing her hands and shoulder inwards towards the midline of her body. That's known as internal rotation. And internal rotation can also be called medial rotation. Internal and medial are the same. If you take a look again at that same picture on the left, there's an arrow pointing inwards towards the midline on her leg. That's demonstrating internal rotation of her hip. When we get you guys into school, we will actually show you how we internally and externally rotate our hips in sitting. It's a little strange, but it's only been going on for about 80 years, so it'll be fine. The picture on the right shows the arrow going outwards. This is external rotation, where the rotation is going away from the midline of the body. And if you take a look at it, it's also known as lateral rotation. So the arm is going out laterally. So internal and medial rotation are the same. External and lateral rotation are the same. This internal and external rotation, they occur in the transverse or horizontal plane. So again, if you take a look at it, remember that piece of glass, it kind of goes through the stomach in the horizontal or transverse plane, creating an upper and lower half. Well, that rotation is moving along that plane. So internal and external rotation, internal known as medial, external known as lateral, goes through the horizontal plane. Elevation and depression. We also elevate and depress our mandible. When we depress our mandible, we're actually opening our mouth. And when we elevate it, we're actually closing our mouth. But what you'll see in most physical therapy is that elevation and depression basically works at the shoulders, and it takes into account the movement of the scapula. When we elevate the scapula, we're actually moving the scapula upwards. And what we would tell our patient is, we want you to shrug your shoulder. Bring your shoulders towards your ear. Depression is the opposite of elevation. This is where we move the scapula downwards and basically return back to the normal position. So elevation lifts the scapula up like you're shrugging your shoulders. Depression returns the scapula back to its normal position. So again, you'll see elevation and depression usually at the scapula, at the shoulder area. And this is a frontal plane motion. All right? Going up and down, up and down. So elevation and depression and a frontal plane motion. Protraction and retraction. You will usually see this in the arms, all right, and the shoulder. It's the scapula that performs this motion. When we protract, it's the anterior movement of the bone. So if you were to hold your arm straight out, and what I want you to do is just move your arm a little bit forward and a little bit back, like you're going to punch something, a little forward and a little back. When we move the arm forward, that's known as protraction. That's the anterior movement of the bone. Retraction is the coming back movement, the returning movement back to neutral. So we have protraction going forward, retraction coming back. This motion occurs in the horizontal plane, right? And again, you will usually see this in the scapula. There is a protraction, retraction kind of movement at the mandible where we move our jaw out and in, out and in. All right, so there is a movement there also with protraction and retraction. But we will see it mostly in the shoulder with the scapula. Supination and pronation. Now, you'll also notice that I typed in the forearm. There is a supination and pronation at the ankle also, at the foot, and we will talk about that. But the supination and pronation at the forearm is a normal movement, all right? This is not a movement of the wrist. This is a movement of the forearm or a movement of the antebrachium. What happens with supination is the radius and the ulnar move the forearm so that the palm faces forward. So that the palm faces forward or faces upward. How would you carry a bowl of soup? You would carry it with your palms faced upwards. So supination, palms forward or palms upwards. This is where the radius and the ulnar are parallel to each other. Remember yesterday when I spoke about the radius and the ulnar, I said that the radius bone is the only bone that moves during pronation and supination. The ulna does not move. The ulna stays stationary. Pronation of the forearm is the opposite movement where the palm faces backwards or faces downwards. Again, this is a spin of the radius. This is where the radius bone crosses over the ulnar, creates an X. So supination, palms up or palms forward in the anatomical position. Pronation, palms down or palms backward in the anatomical position. With supination, the radius and ulnar are parallel, like railroad tracks. In pronation, the radius crosses the ulna and basically creates an X. So again, it's the radius that moves during pronation. And then when it returns, it moves back into its normal position. So we got pronation and supination of the forearm. Pronation and supination really aren't a planar movement. If you were to consider it, it would be a transverse or horizontal movement, but not really a pure plane movement. Remember, I talked about the ankle has a different terminology for flexion and extension. The terms for flexion and extension of the ankle is dorsiflexion and plantar flexion. When we dorsiflex our ankle, we're bringing the toes towards the knee. Bringing your toes towards your knee. That is dorsiflexion. Dorsiflexion and plantar flexion occur in the sagittal plane. So dorsiflexion is bringing your toes towards the knee. Plantar flexion, think about planting your foot, is a bending of the ankle where you're bringing your toes downwards towards your foot. I'm sorry, towards the floor. My apologies. So dorsiflexion, toes goes towards your knee. Plantar flexion, toes goes towards the floor. So in the picture, it's quite clear. All right, you got plantar flexion on the top with the arrow going upwards. Plantar flexion looks like a ballerina. Toes are pointed. Toes are going down. So when we're talking about the ankle, we're talking about dorsi and plantar flexion. Okay? Dorsi and plantar flexion. We also have inversion and eversion of the ankle. If you were to take your hands and make believe they were feet, if you were to move your thumbs towards each other, that would be inversion of the ankle. Inversion is where the soles of the foot moves inward towards the midline, towards the midline. If you take a look here, so here's my left foot, here's my right foot. If I move inwards, I'm coming closer to the midline. Here's the middle. I'm coming close to the midline. That's inversion. Eversion is where we go away from the midline. It's where the sole, if you take a look in that right-hand picture, the sole or even the lateral side of the foot goes away from the midline. So we have inversion going towards the midline or going inwards. We have eversion, was where the foot goes away from the midline. With inversion and eversion, the whole foot is moving. The whole foot is moving. The whole foot moves in for inversion. The whole foot moves out for eversion. The next movement for the foot is AB and adduction. Now remember, we had AB and adduction earlier at the shoulder and at the hip. This is a little bit different movement. All right. I want you to think about, again, we're going to use your hand as your foot. If you were to put your hand on the table with the palm of your hand just hitting the table. So the palm of your hand is the heel. It's your heel. If you were to move your toes outwards, all right, so here's both of my feet. If I was to move my toes, just my toes outwards, keeping my heel flat on the floor, that would be abduction. I'm moving the distal end. I'm moving my toes away from the center. Away from the center. Okay, so abduction of the ankle is where the toes move away from the center. Adduction is where just the toes move towards the center. Again, the distal end, the toes, move towards the midline, towards the center of the body. So inversion and eversion, the whole foot moves. AB and adduction of the ankle, the toes move. The heel is on the ground. Heel on the ground, toes move. If the toes move away, it's abduction. If the toes move inwards, it's adduction. Now, like I said, there is a very special movement at the ankle. And this special movement combines dorsiflexion, eversion, and abduction with one, and with the other, plantar flexion, inversion, and adduction with the other. You have to know this because the national exam loves this question. They love throwing this at you guys. So when I took the test 20 years ago, I make up a lot of little acronyms. I made up a lot of acronyms to kind of remind me of things. Like when I think of shoulder flexion and to remember the muscles that do it, I remember ABC and pec major. Anterior deltoid, biceps brachii, and coracobrachialis, and pec major. Elbow flexors, there are three, BBB, biceps brachii, brachioradialis, and brachialis. Well, I did the same thing here. I don't know, you probably seen, there was a movie out recently about a very, very, very smart dog and a kid that he oh God almighty, that he adopted. All right. It was Mr. Peabody. I forgot the kid's name. But I remember that cartoon as a kid. It was a cartoon back then. So I made up my own acronym. So as long as I know pronation, then supination of the ankle is going to be the opposite. So pronation is Peabody. P is pronation. Pronation is made up of E, eversion, AB, abduction, and D, dorsiflexion of the ankle. Pronation is a combination movement. Both pronation and supination of the foot are combination movements. So if I know that pronation is eversion, abduction, and dorsiflexion, then I know that supination is plantar flexion, inversion, and adduction. It's just the opposite. So that's why I put Peabody at the end of pronation. Again, the P stands for pronation, the E stands for eversion, AB stands for abduction, and the D stands for dorsiflexion. And as you can see, I just did a lowercase y to remind me of Peabody, Mr. Peabody. And I would watch the movie. It's kind of cute, but you know, it was actually a cartoon about 40 or 50 years ago. Yes, I am that old. So it was a fun cartoon back then. They made it a movie, I think, within the last 5 years. So pronation and supination of the ankle. Now, at the neck and the vertebral column, there's also movement. So we spoke about flexion of the head and extension of the head. We also have lateral flexion of the head. Lateral flexion is when we bring the ear towards the shoulder. The ear towards the shoulder is lateral flexion, and rotation is the turning of your head, whether you turn to the left or turn to the right. That is known as rotation. For the back, same idea. If you look at the picture on the left, the young lady is flexing her vertebral column. She's flexing at the hip. The middle picture, she's extending her back. That is back extension. The picture on the right is lateral flexion. In this case, she's performing right lateral flexion of her hip, of the vertebral column. So we have these types of movements also. Again, at the neck, we spoke about cervical rotation, left and cervical rotation right. Well, at the trunk, we also have rotation. If we turn to the right and we turn to the left, that is known as rotation. Okay, so we've got neck rotation, we've got trunk rotation. Now the hands are quite special. All right, and the thumb is a very, very special digit that we'll be talking about. But let's talk about the movement of the hand first. So when we spoke about the hand, we said flexion was going downwards, flexion of the wrist was down, extension of the wrist was bringing it back. Well, we have two other movements. The first movement is known as ulnar deviation. Ulnar, when we're talking about ulnar, we're talking about the ulnar bone. Remember yesterday, we said the ulnar bone was on the pinky side. So ulnar deviation is where we tilt the hand towards the little finger. Tilt the hand towards the little finger. That is the middle picture on the top. Ulnar deviation tilts the hand towards the middle finger. Radial deviation tilts the hand towards the thumb. So we have radial deviation and ulnar deviation. Radial and ulnar. Now I want to show you what happens. This is where things get tricky with the anatomical position. So when I work with patients and their hands, I usually work with them with their hands in a flat position. So what happens is a lot of students get very, very confused. Remember I said in that first PowerPoint is that all movements begin with the anatomic position. But here's the thing. We don't always treat everybody in the anatomic position. But you as PTAs have to think in the anatomic position. So here is your quandary. I'm working with a patient who has very little radial and ulnar deviation. But I'm working with them like this. This looks like it's a transverse plane movement. Remember, think of that glass going through my tummy. Well, it looks like it's a transverse or horizontal plane motion, but it's not. If you put your hand down to your side in anatomic position with your palm facing forward and you perform radial and ulnar deviation, you will see it's actually a frontal plane motion. Again, we have to think of every motion from the anatomic position. You're not going to treat every patient in that position, but you as a PTA have to think that way. So again, ulnar deviation, moving your wrist towards your pinky, radial deviation, moving your wrist towards your thumb. It is a frontal plane motion. All right, let's talk about the fingers, but we're not going to talk about the thumb yet. When we flex our fingers, we're curling them. When we flex our fingers, we curl them. When we extend them, they're straightening out. So flexion and extension. Flexion, extension. Now, also, you might get a little bit more extension of your fingers when you move them back. But as you can see, it's not a big movement. You don't get a lot of extension, not as much as you get flexion. We can also AB and adduct our fingers. When we abduct our fingers, we're spreading them apart. When we're adducting our fingers, we're bringing them back together. Abduction, adduction. And here's the thing. Don't get freaky on me. But the reference point for the fingers is the third digit. Okay, I didn't do that. Okay, we base everything off of the third digit, the middle digit. So when the fingers go away from the third digit, it's abduction. When the fingers go towards the third digit, it's adduction. The reason I'm saying this is because when we do goniometric measurements of the foot, we actually use the second toe as a reference digit. So the reference digit of the hand is the third digit. All right. The finger you blow off people with, and the reference toe in the foot is the second digit. So ulnar deviation towards the pinky, radial deviation towards the thumb, those are frontal plane motions. Flexion of the fingers, extension of the fingers. All right. And if you put your hands down, flexion and extension of the fingers are actually in the sagittal plane. AB and adduction of the fingers. AB, AD is in the frontal plane. And the third digit is your reference digit. Finally, yep, we're gonna finish a half hour early. That's good. We have the thumb. Now the thumb makes us very, very special. All right. It's the use of the thumb that allows us to be the humans that we are. It differentiates us from all other animals because most other animals do not have that opposing thumb. It allows us to perform fine motor movements and larger motor movements. But the thumb is different in its motions. So, thumb flexion is where the thumb goes across the palm. This is thumb flexion, thumb extension. So if you look at the middle part of the picture, you got the thumb crossing the palm, that's thumb flexion. Thumb extension is returning the thumb back to its normal position. Thumb flexion, thumb extension. Thumb AB and adduction are the first two pictures. Thumb abduction is moving the thumb away from the hand anteriorly. So the thumb is coming towards you. This is abduction. When the thumb returns back, it's adduction. Abduction of the thumb going away, adduction returning. We have something known as thumb opposition. Thumb opposition is where the thumb touches the tip of any one of the other four digits. Pinky opposition, fourth digit opposition, third digit, index finger opposition. Opposition is moving the thumb to touch any of the fingers. Reposition is the return of the thumb back to its original position. So look at the last two pictures. So the thumb is touching the pinky, that's opposition. The thumb and the pinky return to its normal position, that's reposition. Thumb flexion and thumb extension occur in the frontal plane. I had to put my hand into that position there for a second. Remember when we did shoulder flexion and elbow flexion, that was done in the sagittal plane. Like I said, the thumb is different. And the national exam loves to pick on it because the thumb is special. So thumb flexion, thumb extension, frontal plane, thumb abduction, thumb adduction. That's the sagittal plane. Remember, AB and adduction of the shoulder was in the frontal plane. So different planes for the thumb because the movements are so different. Opposition and reposition are combination movements. They are what we call non-planar movements. And that should be it. Yay, yay, and hooray. So it was just you two guys, huh?
Yep.
Any questions?
I'm good.
A lot of terminology.
It's pretty straightforward.
I'm sorry?
It's pretty straightforward.
Well, yeah, I mean, that's the beginning of the terminology. I mean, you're going to be learning a whole new language that's really, really in depth over your entire year here. That's the beginning. This is the starting point. So let me stop this video. Give me 1 second. Let me stop the share. I'll stop it. Let me just say on the recording that I will be sending out this video tonight. So everybody knows. Okay, I'll be sending this video and yesterday's video out, and I'll be sending out the lecture material that went along with both of those.